Today's guest is Randy Loveless. Welcome to the show, Randy.
Thank you very much, Elisa. It is my pleasure to be here.
Tell us a little bit about your clinical background.
So I have been a nurse for a little more than 23 years, and I have worked everything from bedside to boardroom. Started out in the emergency department. I did a little work in a trauma surgical intensive care unit. I was a travel nurse. And then I decided to go into management, put some letters behind my name. I was a manager, director, executive director, chief operating officer, and then I traveled around the country with a global company that helps hospitals get better outcomes prior to stopping all of that to start my own legal nurse consulting firm.
How long since you've become a legal nurse consultant?
I have been a full-time legal nurse consultant for 1 year. I've been doing part-time legal nurse consulting now for about 5 years.
That's usually how it starts. A lot of the legal nurse consultants I come across, they start on the side as a side hustle while they're working clinically, which is really good because they still are in touch with the clinical world and everything. And then eventually they can move into full-time consulting. What have you noticed since you started doing it full-time that you feel like is advantageous? And why would you recommend an attorney might find someone who does legal nurse consulting full-time if you do recommend that?
Absolutely, I do. There's advantages of continuing to work on the floor to an attorney because you're getting that real-time experience. But when I was full-time with my normal job and I was just doing legal nurse consulting on the side, I think I was a lot like many people who do that, where I have very limited time to build my business and to grow and learn and develop myself. So now that I'm full-time with legal nurse consulting, it really gives me the opportunity to not just build my business, but to be more confident in the product that I'm able to produce for my attorneys. I'm also available pretty much 24/7. I'm not going to be on the clock. I'm not going to be on shift. I'm not working on the floor. So most of the time, I'm available to my attorney clients.
Randy can be reached at www.lovelesslnc.com. That's LOVELESSLNC.com. So we're here today to talk about a case that you have looked at that was a medical malpractice plaintiff case. I'd love to hear a little bit about the background of this case. I understand it is a surgical case.
So this case was a 50-ish-year-old gentleman who had a cervical spine fusion done. He had history of spinal issues in the past.
Can you explain a little bit to our listeners about what a spinal fusion is, like what that procedure would be like and why someone would need that?
Yeah, the gentleman had a lot of degenerative spine disease. So the bones and tissue weren't lining up. So it was causing subluxations and herniations in his disc. When this gets bad enough, they have to go in and surgically repair it. In this case, that meant that there was a metal cage, essentially, that they put on the spinal column to hold it in place so that it didn't shift. When the surgeon went in and did this, initially it didn't seem there was any issue. However, a year later, and I can tell you how this progressed, but a year later, this gentleman ended up having to go to a different surgeon to have a revision of this surgery. And when the second surgeon goes in to repair it, the site was awful. The suturing line was awful. The wound got infected. And eventually it came to the point to where that second surgery was done. And the second surgeon noted in his documentation that the screws weren't even into the bone. And literally the metal fell out into his hand.
I don't have a background in surgery myself as a practitioner, so help me out on that. Is that something like that happen? How does that happen?
Yeah, so it can. I also I'm not a surgeon, and I've actually never worked in an OR. But as nurses, we do a lot of research, and we understand patients. We understand the human body. So this was a case that I researched for the attorney, and what I found was that 98.25% of these surgeries don't require revision. And this gentleman fell into the 1% or so that did require a revision. And it was quite dramatic.
I understand your background is not in surgery, but you were able to do the research for that attorney. So that saved the attorney, I would say, tens of hours. What would you estimate on that? How many hours have you put in on this case?
Probably 15 to 20 hours.
Wow. So that's probably, I would guess 20 to 25 hours that the attorney didn't have to spend.
Oh, at least. Yeah.
Yeah.
Yeah, I definitely think so. My goal is whatever you spend on me to get these reports and to have me help educate you on the medical aspects of the case, that money is more than recouped in settlement agreements or winning in court. He definitely agreed that the work I did on it not only saved him a lot of time, but it's going to make him a lot more money. He's already increased his settlement negotiations based off of the
Right.
work I did. I think I
Right.
gave him 10 different articles to support my stances. And that number I just quoted came from a journal article saying that 98% of these surgeries are successful. This is not normal. This is not just this kind of thing happens. And the surgeon can't sit up there and say, it's not my fault. It's just because. This gentleman as well did not have a ton of comorbidities.
Did you read the consent form? Was that part of the medical record?
Yes.
Was there any suggestion that this was a possible complication, this specific fallout?
That's the generic. It certainly didn't say the surgery might be a complete failure and the surgery might not be inserted into the bone.
But yeah, a lot of times it's really generic language, and it's an attestation by the surgeon that I have informed this patient of the complications and the probabilities of those complications and everything. And it's an acknowledgement by the patient that they have received that education. Has that been your experience clinically?
Yeah, absolutely. Those definitely help protect the medical professional. But I think the caveat is it doesn't protect the medical professional from a deviation from standard of care or from negligent practice. So some of the things that can cause revision to be needed in a case like this are things like previous infections, diabetes, malnutrition, obesity. Those things were not present.
It sounds really bizarre to me that what you described as the hardware essentially falling out on that second surgery. Offhand, that sounds really concerning. What was the condition of the actual bone? I know bone can have a spectrum of strength to it, just the way that bone anatomically is built.
Yeah, absolutely. You call it a needle in a haystack, right?
Yeah.
I've heard you say before that the nurse is that magnet that goes over the top to pull the needle out of the haystack.
Right.
To go through each blade. The surgeon who did the revision in this case did document not just that the hardware fell out in his hands, but he actually said that the previous surgery had been completely inadequate. And
oh, wow.
And due to the failed surgery, he had to take some different angles and different approaches. He had to get a little creative in his revision because of the first failed surgery. The initial surgeon as well tried to hang a lot of things on the fact that this gentleman was a smoker. And there's plenty of research to support that smoking does delay wound healing.
Does that also have an impact on bone density?
Yes.
Okay, so I can see where he's coming from.
Absolutely. And I think that's an important piece to mention because an attorney might just see that and stop. Dang, he did smoke. He was a chronic smoker. That does decrease bone density. That does delay wound healing. So maybe all of this can be explained by the fact that he was a smoker and they could give up on it. Right?
There's always going to be some scapegoat that they're going to be pointing to, always. And so you can't take that at face value. You have to examine that and look at the research as it relates to smoking and bone density or smoking and fusions, a spinal fusion specifically, and see what that looks like. Did you come across any research specific to the impact of smoking on the outcomes of spinal fusion surgeries?
I didn't find any research specific to that, but we want to tell the attorney the truth of the records, not just what's going to support him, but where his case is vulnerable as well.
Oh, absolutely.
I think it's really important for us as legal nurse consultants to not just give the attorney what they can use for their case, but to also educate them on what opposing counsel can use against them and where the case has vulnerability. And in this case, smoking was certainly a vulnerability. So I had to be very upfront with him about that. The surgeon documented that. Of course, it was going to come up in court, but here's the caveat. So here's another, let's say, vulnerability, or what could be seen as a vulnerability, is that this gentleman had a long history of spinal degeneration and had a previous anterior cervical spinal fusion before. So he had neck surgery before. This was a second neck surgery. The previous one had been done years before. So again, you could look at that on the surface and go, there's so many vulnerabilities in this case, we may not have much of a case. However, when you combine those two, Okay, so there's a 99% chance you're not going to need a revision. He did smoke, so that's going to make you vulnerable. And he has past medical history, so that's going to make you vulnerable. But here's the thing, he smoked before and after the previous spinal surgery, and before and after the revision of the spinal surgery, which, especially when he had to be creative in the way he connected the device, there was a much higher risk of a poor outcome from that revision surgery, but it went beautifully. The patient had a tremendous improvement after revision and did not have ongoing issues after that. It was only that surgery done that was being litigated that had issues, that had poor wound healing, that had a poor suture line, and that ended up having to have a revision.
So the only factor that wasn't present in all those other circumstances was the provider himself, the approach that they took. Did you discover much in your research about the approach that he took and whether it was even among those that are considered standard of care?
Yeah, looking at the actual records from the operation, I saw nothing out of the ordinary.
Yeah, he's the one documenting. So now I'm not an attorney and I never pretend to be one. And I'm careful to make sure that I stay in my lane with the clinical expertise, as I suggest that attorneys try and leave the medical stuff up to the medical professionals. But I'm going to go out on a limb here because I think there's a legal term, res ipsa loquitur. By virtue of the fact that the outcome occurred, we can infer that there was negligence at some point because that's the only way this outcome would occur. From a surgical standpoint, you were able to help the attorney locate a testifying expert that could testify to the fact that this doesn't occur unless negligence happens. And sometimes that just stands for itself. You don't need to point to something in the surgical record where the doctor writes, I improperly placed the hardware on this patient. You're never going to find it. But by virtue of the fact that the hardware is falling out, if you can find a testifying expert in the right field to testify to the fact that that does not occur unless negligence occurred, then that can create a really strong case, because as in medical malpractice cases, virtually all the evidence comes out of the mouth of testifying experts.
Yes, that's a great point. And I did find him a really strong neurosurgeon expert to support the case. In these legal cases, most of the time, it's not a slam dunk, black and white, this side wins and this side loses, right? You have evidence on this side, you have evidence on this side. They're negotiating usually a settlement agreement prior to going to court. Most
Right.
people don't want to end up in court. And in this case, was there the proverbial smoking gun of documentation in the OR?
Never going to happen.
The scalpel? There wasn't. However, like you said, the results indicate that something wasn't done correctly during this surgical procedure. And this particular physician's follow-up was just as negligent.
There was two very distinct negligence incidents here. You've got the surgery procedure itself, and they'll have a testifying expert to say, oh no, his approach was legitimate. Maybe they'll have a testifying expert that even says this does happen sometimes, given people's bone density, given their comorbidities or pre-existing conditions. And it's not necessarily standard of care to say, do a DEXA scan on every single person that goes in for any kind of orthopedic surgery or spinal surgery, right? And the defense will probably get a testifying expert to say, this is not standard of care, to have known that his bone density was that low. And with people with low bone density, this happens. I could see that happening. But what I can't get past is, how did this not get caught? He went for an entire year before this was caught. And by the time it was caught surgically, there was hardware falling out into a surgeon's hands, which means somewhere it went from being secure, supposedly at the time of the original surgery, to being completely dislodged at the time of the second surgery. So it was clearly becoming progressively looser, which, how did he present? What was the manifestation of that?
Yeah, so the gentleman had worsening pain immediately following the surgery.
Meaning worse than the pain he presented with to get the surgery.
Oh, yeah.
See, that should never be happening. We have surgery so that we, right? We have surgery so that we can get out of pain. And you don't ever expect to walk in and come out having more chronic pain. Tell me more.
Yeah, and that chronic is exactly, you mentioned the right word there. You go in, you get cut open, they go in and they mess around in your spine, you're going to have some recovery pain. But this gentleman had worsening pain that continued to worsen and did end up being chronic. About 3 months or so after the initial surgery, he had on x-ray, it was showing some new subluxation, so shifting of the spine, which was exactly what this surgery was meant to correct. And the surgeon followed up on it, saw this x-ray, and documented that it was probably due to arthritis and chronic pain. Then a couple months after that, the gentleman who had this surgery done started complaining of just pain that was continuing to increase at the surgical site and started feeling protrusion sticking out.
Oh my gosh. So how did he describe that?
Feels like metal sticking out of my spine.
Isn't that interesting? Sometimes the layperson may overlook the qualities of pain as described by the patient, because you can expect some acute pain following surgery. And the type of pain is not just pain as pain. The type of pain you would expect following surgery is incisional. It may involve muscle and deeper tissue, because muscle and deeper tissue are cut. And so those nerve endings are disrupted at the time of surgery, but it's going to be incredibly localized and more of a burning incisional type pain than is deep-seated grinding pain or something described like that. And actually, that is a standard of care as a provider and even as a nurse in nursing assessments and in provider exams, to ask the patient subjectively, please describe the qualities of your pain.
Yes. And so this was 3 months after is when the subluxation was seen. 5 months after surgery, approximately, is when the patient started feeling like metal was sticking out. Followed up with primary doctor. Initially, that wasn't documented that they felt anything. There's metal in your spine, so you're going to feel something different. But then here we are now, almost 8 months after surgery, and the primary provider is saying, yes, there's definitely hardware protruding, and noted these knobs that were sticking out that had a lot of pain.
He was able to palpate them on exam?
Yes.
Wow.
Yeah, you should see the pictures.
Oh, wow. Yeah, so that's great that they have that degree of evidence, the images and things like that.
Yeah. And so then they did a CT, which showed that there was loosening of the screws. And there was even screws that weren't entering the bone at all. So this is now 8 months following. So what do you think the initial surgeon that was consulted on this, what do you think he did? He would have said, oh my gosh, let's get another CT. Let's try to figure out exactly what's going on here.
That's what he should have done.
No, he ordered trigger point injections for pain control.
And chronologically and concurrently, someone else is palpating hardware. Yeah. But yet our original surgeon is definitely capable of performing a thorough musculoskeletal exam, and he's not documenting palpable hardware because he knows this is something that I've basically created.
When the gentleman goes for the trigger point injections, a third provider now documents that he has definitely gotten 2 or 3 protuberances under the skin that definitely seems to be the hardware. He's very concerned about it. He calls the initial surgeon up like emergently, I need to speak with you. This is not going well. The trigger point injections are not what this patient needs.
Oh,
There's
wow.
obviously issues with the hardware. And the surgeon said, yeah, but I'm hesitant to do anything more because the patient's a smoker.
Wow. So that's really difficult evidence to overcome right there. Yep. To have multiple providers not only be aware of this, but to try and bring the attention of the provider who's driving this bus, to bring their attention to it and to ask them to do something about it.
So they end up going to a second surgeon. They also, at this point, they contact an attorney. This is when they decided this is not okay. The surgeon's not being responsive. Not only did they do a poor surgery, the suture line, I saw pictures of it. It looked like a third grader did it. It was awful. The pictures of the actual nodules and protuberances on the spine were just, you wouldn't believe. It was obvious to anyone by the time that the revision was done. And then this surgeon kept just blowing it off, it seemed, and not taking any action that would actually fix the problem. We did get another neurosurgeon to back up his testimony. But yeah, neurosurgeons are not a dime a dozen, and it's a pretty close-knit group. And sometimes they are hesitant, especially if it's the guy down the street.
Oh, yeah.
throw them under the bus. So we did get another testifying expert from a different state who doesn't know anybody around here.
So you helped to locate the testifying expert.
Yeah.
I think that's a service that is often overlooked or maybe not known that we provide that service as legal nurse consultants, but it's nice to know that your legal nurse consultant who reviewed the case themselves and they already know that causation narrative, they can help screen that person to find out what their opinions are in general about the type of case prior to letting them look through the records. Tell us a little bit about locating testifying experts. Why is that so challenging for attorneys to do on their own?
I think they tend to put more time and effort into networking with physicians who could potentially be testifying experts. I think they live in the legal world, and the scope of the world is a pretty close-knit group. We live in the medical world and sort of bridge over to the legal world. So we know people who know people. We
Right.
have networks of friends that I've got people I've worked with for 25 years across the country that I can pick up the phone and call. And I know how to navigate through the medical networking. The
Exactly.
attorney knows a bunch of other attorneys.
Yeah. Yeah. It's all about networking. And I think too that if an attorney calls a physician who's never testified before, people get skittish. Testifying is intimidating and it's not for the faint of heart. And it does take a certain personality to be able to do it and do it well. So it's good to find people who have testified before, but sometimes you have to find someone who's never testified before just because they're the right person with the right credentials. And I think that there's a little bit of social proof involved when a fellow medical person reaches out to you and says, hey, would you mind testifying in a case? And I can help set you up with the resources you need to know what you're supposed to do and allow that person to put their toe in the water. I think that there's a little bit less anxiety in being contacted by a medical person than by an attorney calling and saying, hey, would you be willing to testify in court? How intimidating of a call would that be?
Absolutely. And from the attorney side, they have to spend time researching, making phone calls, trying to find a guy that they can get in touch with, setting up a phone call, having the conversation, trying to determine if this is someone that would be good on a stand if they've never worked with them before. We do all that. You vet that expert first. I
Right.
always talk to them. I call that a potential expert, interview them essentially. And I'm trying to determine, is this someone that I would feel comfortable referring to this attorney? Would they do well on the stand? Some physicians are not stand material.
Yeah, it's very true. Also, the process of interviewing, there's a certain degree of finesse and medical knowledge, baseline knowledge that you have to have in order to be able to ask the right questions to figure out, is this the right person? And so delegating that to someone who can intelligently ask those questions initially, because at that stage, the attorney may not always be fully versed in the medical and clinical elements of the case to be able to formulate the questions that they really want to put forward. We were talking before about how legal nurse consultants can pave the way for those testifying experts so that they spend tens of fewer hours reading the records and analyzing them. But the questions that you suggest to the attorney in the depositions go down a certain path that tells a story that they already know to exist in the records because their behind the scenes expert already handed it to them.
I have written cross-examination questions, how to depose your expert, how should you depose their expert, and help the attorney to really formulate that line of questioning.
And I think it's interesting they call it a line of questioning because when you think about it, it's very algorithmic on the stand. I use the air quotes to say line of questioning because it's a tree of questioning. That's a complex process that's best left to someone who knows every branch of that tree, clinically speaking.
That's right. That's a good point. And that's something that we as LNCs do that a lot of attorneys would never think.
I appreciate your time today. Thank you so much for sharing your story. It was a great conversation and I would be happy to have you back anytime.
Absolutely, Lisa. It was my pleasure. Thank you so much for having me on your podcast.
Thank you. You've been listening to Discovering the Needle. Nurse consultants help you discover what you didn't know that you didn't know about how to win your medical malpractice case. This podcast is a production of Discovery NP Legal Consultants. Discovery is the largest unified growing force of specialty nurse practitioners offering consulting services to medical malpractice attorneys who take cases for the plaintiff. Nationwide nurse practitioner consultants to the legal profession, or NPCLPs, at Discovery NP Legal Consultants include specialists in orthopedics, and first assists in spinal and other surgeries, as well as a host of other specialties. To request a consultation or to be featured as a legal nurse consultant on our podcast, you may reach us on our website at www.nplegalconsultants.com or by calling 208-779-1990. That's 208-779-1990.